I think DMD regarding newborn screening has been discussed for a long time in the field. And I do believe things progress in the forward way. And personally, I feel this is the time. Why I say so? And I think two parts. One is the test. So when we talk about the newborn screening, we need a simple and quick, robust, and the way to do that. And second part is, if we identify the kids, can we confirm them, and can we treat them? So I think DMD has come a long way in terms of treatment. Two parts. One is we have some called exon skipping, the molecular-based technology, and a lot of drug development is in the place right now. Second part, even we use traditional steroid therapy and we're getting better. And I do believe a lot of discussion has occurred in terms of utilizing steroid in children. So that's one part of that, another technology part. And we do know the sensitivity, specificity, and I recently have the opportunity to work with biotech company, and I do believe we come to a pretty good immunoassay and allowed us to have a first tier. Then we understand the genetic part of DNA pretty good. Then we can use a second tier testing to find the molecular, the defect. So that was just like we do for cystic fibrosis, and a two-tier approach will allow us to do screening. I think depends. You can do either way, in my opinion. The reason is the second tier molecular testing for DMD is not simple because you require, detect a large deletion and duplication can be a little bit complicated. And some laboratory may choose to do themselves and develop assay, which is fine. And some laboratory maybe say, hey, I'm just going to send someplace else to second tier, which is fine too, in my opinion, because DMD compared with the traditional metabolic, like organic aciduria disorders, they do have a time to react. So take some time to get molecular testing, and it's suitable for these disorders. Wow, that's a tough question. And I think to me, and I think we have a technology, I do believe the molecular assay we can get pretty good. And the things I do believe we need some pilot study. So we need a population-based pilot study and generate evidence. So in the US, we can use evidence-based information to make a decision. So I believe will take some years. I would say both sexes, boys and girls, and let me tell you why. We know DMD is X-linked disorders, and which means boys usually symptomatic, and theoretically, girls should be okay because they have another X chromosome. But unfortunately, naturally, in general, when the gene laid on the X, and because the gene dosage have to be balanced, so one of the X in a female will be, we call it inactive. And this is supposed to be happen randomly. But unfortunately, sometimes we call the term in the genetic called acute inactivation. If you have two copy all normal, doesn't matter which one get inactive. But when you have a female, we call the carrier, you have one copy normal, one copy defected. When they're acute inactivation, they potentially could inactive normal copies more. In that situation, the girls will have symptoms. So that's the part one. Part two is, if we're going forward with the two-tier testing, The first we use called creating kindness. If girls have acute inactivation, they will have elevated CK, and you can identify actually that potentially is a benefit for us to pick them up, not a quote-unquote carrier. Even they have one normal gene, but because they get it inactively, so they still have symptoms. Does that make sense? One thing I want to add on is every disorders have a unique situation, and we need to understand, and we have to have procedure in place to take the system approach, and I think we'll be success.